2 वक्ता हैं, तो सबसे पहले मैं डॉक्टर ज्योत्सना जो हमारे पपरोला से ही यूजी पीजी हैं, हमारी स्टूडेंट है, अभी एनआईए में कार्य कर रही है, तो उसका मैं स्वागत करती हूँ। तो सबसे पहले इनवाइट करूँगी डॉक्टर ज्योत्सना को। ज्योत्सना, ओवर टू यू।
Thank you, ma'am. Thank you so much. First of all, a very good evening to all the respected dignitaries present over here. First of all, I would like to thank Professor Kamini Diwan, ma'am, for giving me this opportunity to share my views on this platform. Thank you so much, ma'am. Ma'am, my voice is audible?
Yes, audible.
Okay, okay, ma'am. So, should I start the presentation?
Yeah, yes, you can share the screen and present. Yeah.
Okay, ma'am. Is it visible?
Yes, yes, it's visible. Your slide is visible. इसको हम स्लाइड शो मोड में भी कर सकते हैं।
Okay, ma'am. So, good evening, everyone. My today's topic is Prasava ParicharyA. So, contents of the presentation will be overview of the labor and its stages, key aspects of each stage, how we have to evaluate and management of the first stage, second stage, and third stage, then Ayurvedic perspective of labor management, and finally conclusions. All these contents we are going to deal in this presentation today. First of all, introduction about the topic. As we all know, labor is a clinical diagnosis, and we can define it as a effective, coordinated, involuntary contractions that result in progressive cervical effacement and dilatation, and progressively results in the birth of baby. This is the clinical definition of labor. Although we know that childbirth is a physiological process that can be accomplished without any complication in majority of the women, and globally we see that 140 million births per year occur without any complication and without any complications and throughout the labor process. But still, time and process of the birth is very critical because of the high risk of mortality and morbidity if any complication arises. That's why management of labor is very essential, and evidence based good quality care is key to comprehensive management and for successive outcome of um, mother as well as baby. When we see the statistics of maternal mortality rate in India, we find that in NFHS 16 survey, it was 130. But now it has declined to 97 as per an NFHS survey 20. This is because of the good care that is being provided during the antenatal period, intrapartum period, and postnatal period. That's why MMR has reduced. And so we are focusing on the labor management processes. Our aim is delivery of normal healthy baby from a healthy mother. We have to anticipate, recognize, and treat the potential complications at its earliest possible moment and do needful management so that we can perform timely and accurate clinical interventions for any abnormal deviation and to provide a positive birthing experience that is very much essential for the mother. When we see the WHO intrapartum care module, we see that WHO has led very comprehensive and consolidated guidelines on essential intrapartum care to ensure good quality and evidence-based care irrespective of the settings of healthcare. So the components of this module are mainly respectful labor and childbirth care. That is, we have to organize a care which maintains the respect, confidentiality of the patient. Second is emotional support is very much essential for positive birthing experience. Companion of choice should be allowed to the patient. Effective communication should be there between the healthcare providers and the patient. Various pain relief strategies should be allocated as per the patient preferences. And main thing is intensive monitoring, documentation of the events through by plotting a partograph that is very much essential to detect any deviation and then promptly acting against that intervention. Then oral fluid intake and food intake is recommended as per WHO module. Mobility and different birthing positions of choice that should be recommended, and pre-established referral plan should be there if any complication arises. So continuity of care is the main aim of WHO intrapartum care module in antenatal, intrapartum as well as postnatal period. So when we talk about the normal labor, we find that what is normal? Actually, this is a matter of debate about the normality of labor, because normal going process can be abnormal at any stage, but still there is a criteria which defines normal labor as the labor which occurs spontaneously, which occurs at term, which progresses without undue prolongation or assistance, having vertex presentation, there is a natural termination, and which occurs without any complication, that is termed as normal. We know there are four stages. First stage starts from the onset of true labor pains up to full dilatation of cervix. That is 12 hours in primigravida, 6 hours in multigravida. Second stage starts from the full dilatation to expulsion of fetus, 2 hours in primigravida and 1 hour in multigravida. Third stage starts from expulsion of fetus to expulsion of afterbirths, and it is 15 minutes in both primi and multigravida. And fourth stage is the observation stage that lasts for 2 hours after delivery, in which we observe the patient for any uneventful outcome. The main principle which we should follow as per WHO module are: first thing is accurate diagnosis of labor. First of all, we have to diagnose by intensive detailed history taking and by thorough examination that patient is actually in labor or not. As per this module, we should admit the patient when the patient is in active labor stages. So accurate diagnosis is very much essential. Second thing is monitoring or evaluation of the progress of labor. And third thing is we have to ensure maternal as well as fetal well-being. So these are the main principles which we will talk about. Now, first stage is we know that during the first stage, major events are cervical dilatation and effacement, formation of lower uterine segment, and expulsion of show that occurs because of the uterine contractions and retraction. So, what parameters we have to examine during the we have to monitor during the first stage, that is mainly uterine activity, cervical dilatation, effacement, all these parameters we have to evaluate during the first stage. Principles are non-interference with watchful expectancy. That means during the first stage, this physiological process is going on by itself. We should not interfere. We should have only observancy. A careful monitoring should be there. And we have to monitor the progress, maternal condition, fetal behavior, and we have to detect any intrapartum complication promptly. So that is the main principle of management in first stage. So first we will have to diagnose whether the patient is in first stage or not, whether the true labor has occurred, started or not. So we have to first diagnose that. Then we will monitor the progress and we will plot it in the partograph, and then we will go for the preparation and care. So for diagnosis or assessment, first we will do detailed history taking, because we need to synthesize the findings on history and examination to confirm the diagnosis of labor. Then only we can decide that we should admit the patient in labor room or not. So first we will go for detailed history taking. We will review all the antenatal records whenever patient comes to us and she is complaining of labor pain. Then first of all we will review all the antenatal records, including examination, investigation, or whatever USG she has done. Then we will confirm the EDD as per her LMP, or if LMP is not known, then according to USG we will confirm that what is the EDD of that patient. We will inquire complete obstetrical history. We will inquire the history of present pregnancy, any medical disorder, any complication during that pregnancy. We will inquire about the history of present labor pain in terms of frequency and duration, and history of regular intermittent contractions or tightening of the abdomen is there. We will inquire all these questions. Then history of sudden loss of any blood stained mucus or any watery discharge per vaginum, or history of backache, history of changes in the intestinal habits in the last 24 hours. So all these questions we will ask from the patient. Secondly, we will go for examination. We will examine the patient abdominal examination as well as pelvic examination to confirm our diagnosis whether the patient is in labor and we have to admit her or not. So abdominal examination, we will evaluate uterine activity. There are certain characteristics of uterine contractions which need to be monitored. That is frequency of contraction. That means at what interval contractions are occurring. We will observe the patient for 10-minute period of contractions. We will keep our hand on the abdomen of the mother and we will observe for 10 minutes that at what frequency contraction is coming or uterus is getting hard. Second thing, we will observe the duration, that for how much period that hardening persists, that is the duration of contraction. And third thing is intensity. Intensity means degree of uterine systole, that is measured by indenting the abdomen at the height of uterine contraction. We will indent with the finger and we'll see that if it is indented easily, then it is mild contractions. If it is indented with certain force, then it is moderate contraction. And if it at the height of contraction we are not able to indent the abdomen, that means contraction is very strong. So in this way we will know the intensity of contractions. And all this activity is evaluated by manual palpation. We observe the patient for 10-minute period, and we see that how many contractions are occurring, for how much duration they are occurring, and how is the intensity of that contraction. That all should be monitored. Initially, frequency is very low. That in contractions come at very longer intervals. This persist for very short duration. Intensity is also very low. But as the labor progresses, this frequency decreases and duration and intensity increases. So we can say that contractions are just like Wi-Fi signals. They get stronger when we get closer to the delivery zone. So in this way, we will evaluate the uterine contractions for 10-minute period. Secondly, we will assess the descent of the fetus. We know that descent of the fetus is very, very important for normal delivery. And here the progressive descent is ascertained by noting how much fetal head is present in the abdomen, and it is felt suprapubically in finger breadth by placing the radial margin of the index finger above the symphysis pubis until the groove of neck is reached. Here we can see in the picture, if 5 by 5 head is in the abdomen, or 4 by 5 head is in the abdomen, or 3 by head is in the abdomen, then we can say that head is not yet engaged. But if only 2/5 is felt, then that means head is engaged. And in this way we measure the progress, whether with the progress of the labor descent is occurring or not. Third thing that we have to measure is assessment of cervical dilatation, because it is a major event which takes place in the first stage. So we will measure the dilatation. Dilatation means dilatation of the external os, and we can measure it through vaginal examination. It ranges from 0 to complete 10 centimeter dilatation, and our one finger represents 1.5 centimeter on an average. Normal rate of dilatation in primary gravida is 1 centimeter per hour, and in multigravida is 1.5 centimeter per hour during the active phase. So we will measure that whether this with this pace cervical dilatation is occurring or not, or it is protracted. So accordingly we have to manage. Next thing is assessment of cervical effacement. Effacement means taking up of the cervix. That means the thickness of the cervical canal is getting less or not, and it is represented in percentage. If the cervix feels very thin, just like a paper, then we can say that it is 100% effaced or fully effaced cervix. It is very necessary to measure the cervical effacement, because it is required for diagnosis of the active labor, as well as if and there is any delay, then we need and we have to do any active intervention, then we see whether the effacement is occurring or not. Accordingly we have to manage. Next, we have to assess fetal station on PV examination. Station means it is also a measure of descent on PV examination, that the bony presenting part, which is coming throughout the birth canal, how much distance is there from the leading bony edge from ischial spines. We consider at ischial spines level station is 0, and if it is 2 centimeter above, then we can say the station is -2. If it is 3 centimeter above, we say station is -3. And when it crosses the 0 station and it is 2 centimeter below the ischial spines, we say the station is +2. So accordingly, we measure the descent by assessing this fetal station in terms of centimeters from ischial spines. Next, we have to assess fetal head position. Head position means relation of the denominator to different quadrants of the pelvis. What we do, we divide the pelvis into 8 quadrants. 8 quadrants are there. Now, the fetal denominator is occiput encephalic presentation. So we will see that the occiput is present at which position, whether it is present towards the sacral promontory or it is present towards the pubic symphysis, or it is in the lateral positions. So accordingly we name them. If it is towards the sacral promontory, we say it is occipito posterior position. If it occipit is towards the pubic symphysis, we say it is occipito anterior position. And if it is transverse positions, then we call it lateral or transverse position. So accordingly we call it position. And it is measured or determined by the palpation of posterior fontanelle, that is lambda. On PV examination, we try to find the Y-shaped suture, and the at which position this Y-shaped suture is present, and that is termed as fetal head position. With successive examination, then we keep an account that whether this position is changing or not, whether this occiput is coming towards the pubic symphysis or not. This is very important, because if there is no internal rotation, then delivery will not take place. Normal delivery will not occur. So this is essential that fetal head position should be evaluated by determining this posterior fontanelle or Y-shaped suture. Next, we assess the degree of flexion of the fetal head by palpating the anterior fontanelle. It is a diamond shaped. It is of diamond shape, also known as bragma, and we palpate this. But if the head is well flexed or chin is touching the chest of the fetus, then in that case we are not able to palpate the bragma. So that means fetus is well flexed. But if the head is deflexed or it is extended, we can easily palpate the bragma, and that denotes the deflexion, and that means there will be a delay in the labor. So all this we have to assess during the first stage. Along with this, we also see the membrane status. We know that amniotic membranes are attached to the cervix very loosely. So when contractions start, these membranes get detached from from the cervix, and a loose pouch is formed, that is known as a bag of water. And some water comes into some amniotic fluid comes into that bag. That's why we call it a bag of water. And if that pouch is present, that indicates that labor has started. And we see that that pouch is present, and sometime it gets ruptured. Then we assess the color of the liquor, whether it is pale straw colored, which is a normal color, or is there any deviation from the normal color that indicates abnormality, and accordingly we have to manage that condition. So we have to assess the membrane status as well. Along with this, we have to assess the pelvic adequacy. We assess whether the clinically this pelvis is adequate for that baby or not. For measuring this, we measure the diagonal conjugate. Diagonal conjugate is measured from the lower border of the symphysis pubis to sacral promontory using the tip of middle glove finger by depressing the wrist and elbow to reach the promontory, and then we mark that point. And we see that if it is more than 12.5 centimeter, that means this inlet is adequate. Secondly, we see the sacral curvature, whether the sacrum is well curved or not, because sacrum should be well curved for normal delivery to occur. And along with the sacral curvature, we see the side walls of the sacrum, whether they are straight, divergent, or convergent. Convergent walls indicate that the mid pelvis or this outlet is constructed. So we have to see the sacral curvature. Next thing is ischial spine prominency. We will see whether it is blunt, prominent, or very prominent, and we will measure the interspinous diameter. For that, what we will do, we will try to touch the both spines simultaneously. If we are able to touch both spines simultaneously, that means this diameter is small and there will be obstruction at this point. And if we are not able to touch both the spines simultaneously, that means this diameter is adequate. Then coming to the outlet, we will measure the intertuberous diameter. What we will do, we will just put our clenched fist under between the ischial tuberosities, and if our fist accommodates between the ischial tuberosities, that means the outlet is adequate and fetus can come out of this pelvis. So in this way, we measure whether the pelvis is adequate or not. Along with this, we evaluate maternal vital signs, her blood pressure, temperature, respiratory rate, pulse rate, examine the tongue of the mother, and note the urine output for assessing the hydration status, and examine the lower limbs for any evidences of edema. All these parameters are also evaluated during the first stage for monitoring mother. Along with this, evaluation of the fetal condition is also done. Fetal heart sound should be monitored every half hour during the first stage, either by using a stethoscope or using a Doppler. As per WHO module, CTG monitoring is not recommended in normal cases. It is reserved for the high risk cases during the labor. Normal range, as we all know, is 120 to 160, and during contraction, there is slowing of the FHS by 10 to 20 beats, but it returns to normal as contraction passes off. So we keep on monitoring the fetal conditions also during the first stage. So in this way, we monitor the patient. Then what we do, we plot that progress on the partograph. So partograph is a graphical information. It is just a graph which shows the progress of labor and codes all the silent information about the fetal well-being, maternal well-being, progress of labor. This partogram has 11 components, but the major components are includes mother information, that is the patient information, fetal well-being, including fetal heart rate, character of the liquor, whether it is stained or whether it is clear, and the next is molding. Then labor progress in the terms of cervical dilatation, head descent, uterine contraction patterns, whether they are mild, moderate, or strong. Then medication, what medications have been used, and maternal well-being in the form of blood pressure, pulse, temperature. All this is plotted on this graph. And why we need this graph? This is very essential to plot all the findings on this partogram, because it provides a continuity of care. It provides a basis of decision making. If we need to take any decision, if any labor is crossing the alert line, or if it is crossing the action line and we need to take an action, then it tells us that when we have to take the decision. That's why partograph plotting is very important. And it also defends us our actions, because we know that if there is no documentation, then no defense is there. So partogram plotting is very essential in each and every case, that helps us in decision making. So partogram should be plotted. Third thing that is essential in first stage is preparation and care. We have to give encouragement and motivational support to the patient. Second thing, perineal preparation. Mostly vulval hair clipping is to be done, because as per WHO module, this vulval hair shaving is not recommended. That is contraindicated. We allow the patient, if the membranes are intact, we allow the patient to walk. When we talk about nutrition, food is permitted during the active labor as per the condition of the patient. If there is no risk evident, then we can allow food, and if there is an evident risk, then we can allow liquids in the form of plain fluid or glucose water or coconut water. Apart from that, fluid management, that iodine is started to prevent dehydration, and bowel enema is given, or we can give us basti with the shmool iron, so that to clear the bowel. And next is bladder care. Encourage patient to pass urine by herself every 1 to 2 hours, as labor as full bladder inhibits the contractions, and that may also lead to infection. So always encourage the patient to pass urine by herself during the first stage of labor. But in later stages, if she is not able to pass the urine, then catheterization is to be done with aseptic precautions. So this was the management of the first stage. So basically, in the first stage, as per WHO module, we have to do only the watchful expectancy. We have to diagnose labor, then we have to assess, monitor the labor, and we have to evaluate the maternal and fetal conditions, and general management is there. Then we will come to the second stage. We know that second stage starts from full dilatation to expulsion of the fetus. So here two major events are taking place: descent of the fetus, and second thing is delivery of the fetus. Clinically, this stage is evidenced by increasing intensity of the contractions. Now the contractions become more and more stronger. Patient feels urge to defecate with the descent of presenting part. There is complete dilatation of the cervix as evidenced on a vaginal examination. There is anal gapping with perineal bulging. Rupture of the bag of membranes is there. Appearance of bearing down efforts is there. So we can clinically evidence that second stage has started. So here our main aim is to assist in the natural expulsion of the baby, and secondly, we have to prevent perineal injury. So for this, what preparation we have to do? First thing is we have to maintain the maternal position. Allow the mother to sit in any recumbent or dorsal position with 15-degree left lateral tilt to avoid artocaval compression, so that the blood flow to the fetus should not be interrupted in supine position. That's why 15-degree left lateral tilt can be given. Secondly, for our safety purpose, we should put on personal protective attires. We should practice hand hygiene, and we should place the plastic sheet or callus PA pad under the woman's buttocks and place the perineal sheets or leggings there. Second is perineal cleansing. Antiseptic cleansing of the skin over the lower abdomen, vulva, upper thighs should be done with antiseptic solution. And we have to focus on the 7 C's of the delivery. 7 C means clean hands, clean perineum, clean delivery surface, clean cord tie, clean cord stump, clean blades, and clean swab. All these 7 C should be maintained. Then technique of perineal cleansing. This technique is very very important because most of the time what happens, delivery is conducted in aseptic in septic precautions. Aseptic precautions are not followed, and because of that infection occurs, and that leads to various morbidities. So perineal cleansing technique is very very important. We should follow 6 swab wall technique for sequential cleaning of the perineal area. First of all, we should clean the mons pubis with the first swab, then right labia majora and inguinal folds with the second swab. Now clean the left labia majora and left inguinal folds with the third swab. Then come to the inner aspect of the left labia minora with fourth swab. And after that, clean the inner aspect of right labia minora up to the anal margins with fifth swab. And with the last sixth swab, we have to clean the vaginal introitus. This is the perineal cleansing technique known as 6 swab technique that should be followed. And if the patient is not able to pass urine and bladder is full, then we should perform catheterization in this case. Then next is monitoring. Here also monitoring is essential because there are 2 phases. First is propulsive phase, in which there will be descent of the fetus up to the perineum, and second phase will be expulsive, in which baby will be delivered outside. In propulsive phase, we have to do monitoring. We will reevaluate the uterine contractions, their frequency and intensity, because sometimes what happens, the contractions cease or contraction decreases, so that leads to delay in the second stage of labor. So we will evaluate whether the contractions are effective or not. If in 10 minutes period of observation 3 contractions are occurring with moderate to strong intensity, with the duration of for the duration of 45 to 60 seconds, that is effective uterine contractions, and they are effective for progress of the labor. Again, we will evaluate the bearing down efforts, because now in the second stage, bearing down efforts will emerge. Now the mother will start pushing, voluntary expulsive efforts will appear. Here we have to instruct the woman to exert downward pressure only along with contractions. And premature bearing down should not be done, that suggests uterine dysfunctioning. So only during the second stage this bearing down efforts appear. Here again, we will evaluate fetal position by palpating the posterior fontanelle. As I told in the first stage, we will again assess the fetal station. We will again see the fetal descent is occurring or not. Every 30 minutes, we will assess it, assess the degree of flexion, and also reassess the effective fetal weight to rule out the CPD. So again, we have to evaluate all these parameters in the propulsive phase. Then evaluate the membrane status, whether intact or ruptured, and assess the color of liquor. Because if the liquor is meconium state, then we have to expedite the deliveries. That's why it's very important. Evaluation of the fetal behavior, FHS should be monitored every 5 minutes during the second stage, either by the stethoscope or Doppler. And mother is also evaluated for blood pressure, pulse rate, respiration. There is increased features of maternal exhaustion are evident during this stage. Now coming to the expulsive phase. Now the fetus is ready to deliver. So we have to conduct the delivery. There are certain features which tell that expulsive phase has started, like mother irresistible desire to bear down. Now mother bear downs irresistibly. There is distension of the perineum. 4 to 5 centimeter of the scalp is now visible on the perineum. Dilatation of anus is occurring. There is anal gapping. Excretion of the urine and stool is there. That means expulsion phase has started. And now we have to conduct the delivery. So first of all, there is controlled delivery of the fetal head should be conducted. And for that, flexion should be maintained. Maintain the flexion of fetal head. Encourage the patient to bear down only during the contractions. And if you feel that there is a need of episiotomy, then when Ball's thinned perineum is there, then during contractions, episiotomy should be given. In routinely, episiotomy is not recommended It is recommended only in cases when there is a tough perineum, or if there is a fetal head is big, or there is any abnormality in the perineum, then only routine episiotomy should be given. Routinely, it should not be given. The next, we will conduct the delivery of head. So regulate slow delivery in between the contractions by modified Ridson's maneuver. What we will do in this maneuver, as the crowning occurs and fetal head is going to come out, we will exert forward pressure on the chin with the right hand through the perineum, and concurrently with the left hand we will exert pressure superiorly against the occiput. In this way, we will conduct the delivery of the head very slowly, and along with that continue to support the perineum as head and shoulders deliver. After the head is delivered, we will suction the baby's mouth and nose. Then we will palpate around the baby's neck for umbilical cord. If cord is present and is loose, then we will slip it over the baby's head, but if it is tight around the neck, then we will double clamp it, and then we will cut it with the scissor and then unwind it from the neck. After the delivery of head, now we have to conduct the delivery of shoulders and trunk. Now, don't be hasty at this point. Wait for the next contraction and movements of restitution and external rotation to occur. Then first we will deliver the anterior shoulder. For that, what we will do, we will grasp the fetal head gently with both hands and draw posteriorly until the anterior shoulder is released from the pubic symphysis. Then we will deliver the posterior shoulder. Now we will pick the head in upward direction to deliver the posterior shoulder out of the perineum. When both the shoulders are out, then we will insert our fingers under the axilla and then deliver the trunk gently by the lateral flexion. So this is the method of delivering the baby. After that, we will wait for 1 minute for 30 to 60 seconds, as the delayed clamping is advised or recommended, because it will provide more blood to the fetus. That's why we will wait for 1 minute, and delayed clamping is advised if any contraindication is not present. And then after that, third stage start. Now the after expulsion of fetus, now we have to expel the placenta and the membranes. So third stage, mainly what will happen, there will be separation, then there will be descent, and then expulsion of the placenta will be there. We have to ensure strict vigilance to follow the management guidelines strictly, because third stage is very crucial stage. So we have to ensure very strict vigilance during this stage. We will allow the separation and examination and repair of episiotomy. This includes the management of the third stage. First of all, during the third stage, we will observe for classical signs of placental separation. That is very, very important. We will see for three classical signs. First is lengthening of the umbilical cord. That is very definite sign of placental separation. Secondly, we will see for the gush of blood from the vagina, which signifies separation of placenta from the uterine wall. And third thing, we will see for the change in the shape of uterine fundus. That is, from discoid, it becomes globular, and there will be elevation of the fundal height, because if the placenta separates, it comes into the lower segment and the uterus rests over it. So there will be rise in the fundal height. So we will observe these three parameters, and if these three parameters are evident, then we understand that the placental separation has occurred. Now we will move toward the active management for the placental expulsion. For active management, what we will do, here are again three steps are there. First step is give uterotonic drug immediately. That is, give oxytocin 10 international units IM. Secondly, deliver the placenta by controlled cord traction method. CCT method should be adopted. For this, what we will do, we will place the palmar surface of the fingers of left hand above the pubic symphysis, and will push the body of the uterus upward and backward. While with the right hand, we will hold the cord and gently downward backward direction. Gentle traction is provided when the uterus feels hard and contracted. In this way, we will deliver the placenta. Here, two key points should be always kept in mind. Don't perform controlled contraction when no contraction is present. That means CCT should be performed only when contraction is there. And secondly, without applying contraction, CCT should not be done. If you will give traction without any contraction, you may cause uterine involution. So always remember these points during CCT performance. Third step is fundal massage. Give fundal massage after delivery. For that, One hand is cupped to massage and gently compress the uterus fundus towards the lower uterine segment, and keep the other hand against the uterus at the level of pubic symphysis to support the uterus, and then give the massage. This is the way of giving fundal massage. So these three parameters for active management of third stage of the labor should be adopted. After that, we will examine the placenta, membranes, and perineum for its completeness or for any missing lobe. Then we will examine the perineum, vulval outlet, vaginal canal, and cervix for any tears and lacerations, and we'll see whether any tear and laceration that has to be sutured. After that, if episiotomy has been given, then we will go for the repair of the episiotomy. So this is the management of the third stage. Now coming to the fourth stage of labor, this is an observation stage. Here we will closely observe the mother's vitals. We will keep continuous assessment for ongoing bleeding, that how many pads she has soaked. So we will have a continuous assessment for that. And similarly, also we will go for continued intermittent uterine tone assessment, whether the uterus is well contracted or not. So we will observe for all these parameters during the fourth stage of labor. So this was the interpartum care module, which has been advocated by the WHO for the management of labor. Now coming to the Prasava Paricharya or management of normal labor Ayurveda perspective. What Ayurveda says. When we see the management protocols, we see that mainly monitoring is the target in the interpartum care module. Mainly they have focused on the monitoring and detecting any complication at the earliest possible moment. Whereas in Ayurveda Paricharya, a very holistic patient centered approach is there. They are focusing on the patient's positive birthing experience. So that is the main aim of Ayurveda Prasav Paricharya. So Prasav means Garbha Moksha or Mukti from the Garbhabhasa, whereas Paricharya means care which is given in all aspects, whether it is physical, mental or psychological aspects, all form of Paricharya is given. So that means Prasav Paricharya in Ayurveda is very comprehensive management that includes care given to all the aspects, whether it is physical, mental or psychological. All the features has been addressed, because the main aim of Prasav Paricharya in Ayurveda is Sukh Prasav. And Sukh Prasav, here Sukh Prasav means, Sukh means Anukul Vedana. So when the Vedana is Anukul to the patient, when the patient feels comfortable, her perception about the birth is positive, then that is Sukh Prasav. So this is the main aim of Ayurvedic Prasav Paricharya. In Ayurveda also, Prakrit and Vakrit Prasav has been mentioned, and various conditions has been told that tells that Prasav is Prakrit or not. Like Swabhava, that is spontaneous onset should be there. Upasthit Kala, at term should be there. Avaksira, that means vertex presentation is there. Then it is Prakrit Prasava. Swabhavik Kala, if it occurs in the Swabhavik, that means without undue prolongation, it gets terminated, then it is Prakrit Prasava with internal rotation, Parivritya and Updrav Rahita, that is without any complication it occurs, then it is Prakrit Prasav. Similarly, Prasava Avastha has been mentioned, and these are Prasayini, also known as Prasava Utsuka, Asan Prasava, called as Prasanan Kala Bhimata or Prasava Utsuka, Upasthit Prasava by Acharya Shushruta, Parivartit Garbha by Acharya Charak, Bhagvat and Kashipa, and Apra Nirgaman by all the Acharyas. When we see the clinical features of these different stages, we find that they are telling about the clinical signs of each stage of the labor. This clinical features of the Prasayini correlates with the prodromal stages of labor, when the labor has not yet started and there is a prodromal state which starts 1 to 2 weeks before the onset of true labor. So no management has been told about the Prasayini. Whereas Asana Prasva or Prasanan Kal Abhimata, as said by Acharya Charak, the clinical features of this stage resemble with the first stage of the labor, and Paricharya has been mentioned for this Asana Prasva. Similarly, in Upasthit Prasva, clinical signs resemble with the end of the first stage and beginning of the second stage. That is mainly the second stage of the labor. And for that also the Paricharya has been mentioned. Similarly, in Parivartit Garbha is also second stage of the labor, and for that Paricharya has been mentioned in Ayurveda. So as I told, Prasini, Lakshana of the Prasini is Jate hi shithile kuksha mukte hriday bandhane. So these features are suggestive of prodromal labor when lightening occurs and there is relief of compression, laxity in the flanks, and no management has been considered for the prodromal stage of the labor because it is here true labor has not established yet. Now coming to the signs of first stage that resemble with asanna prasava. Here, the features we will see that there are clinical signs. They told that there is the first stage of labor, like there is a gatra klamta malaise is there, clumsy face is there, and adho gurutum, there is heaviness in the lower region as the pelvic presenting part has sinked into the pelvis, and yoni prasravanam, that means blood mixed mucus known as show is evident here, and avi pradurbhava, that is avi is prasab kalja shul vishesha. So avi means uterine contractions. There is onset of true labor pain or uterine contractions there. Garbhodak praseka, that means leaking per vaginum is there. So all the features are suggestive of first stage. Now see what Acharya has said for the management. First, they have told about the maternal position. Bhuma shainam mridu vastaranam kritopdhan abhugan sakti utan shain. That means female should be allowed to lie on the this on the ground with the soft bed, or we should allow her to lie in any upright position, like by giving with the flexed legs and by giving a pillow for support. Kritopdhan means a pillow for the support should be given. So we see that this position is an upright position, most likely semi-fowler position, that is 45 degree to the horizontal. This position should be given. So this is an upright position. Why they have mentioned that female should be advised to lie in this upright position in the first stage? Because it increases pelvic dimensions by the rotation of outward rotation of the pelvic joints. Secondly, it is an upright position, so it aids in the descent of the fetus due to gravity, which is required during this stage. Third thing is it enhances the uterine contractions effectively because the wave of contraction passes through the uterine fundus towards the cervix, so enhances the contractions, reduces pain perception during the contraction, so lessens the chances of fetal distress, and also shortens the duration of labor and reduces the operative interference. So this is very scientific that the maternal position, whatever they have mentioned, that kritopadhana abhuman sakti utan shayan should be given. Uh, an article is published in the PubMed, which also indicates that the upright position is given during the first stage of pregnancy, that it has very good effect on the maternal outcome, as it reduces the duration of labor and incidence of perineal laceration is very less if the upright position is given. So we should follow this management protocol during the first stage of labor, and we should allow her to lie in the upright position. Secondly, Ayurveda has focused on the non-pharmacological pain management intervention. Mainly, they have focused on the positive birthing experience. That is, the perception of labor should be positive. For that purpose, they have mentioned a lot of distraction techniques or a lot of manual techniques by which we can provide pain relief to the patient. First thing is Krit Mangal Swasti Vachanam. They have mentioned that regular recitation of some hymns or mantras should be performed during the first stage of labor. It is a type of distraction technique. That is, by distracting or focusing on this recitation of hymns or mantras, we will draw the attention from pain to another direction. And this is a very important method for coping the labor pain. So, and secondly, they have also mentioned Hast Punam Phal Dharan or Kumar Parivita. That means some children should be there or she should hold her Punam Phal. So that is also a distraction techniques. Virtual reality type of distraction technique is that. So these techniques will remove the transmission, will block the transmission of painful stimulant to the central nervous system, and they will induce calmness and they will relieve the stress, and this will favor the progress of labor, because we know that if there is stress during labor, then stress leads to cortisol secretion. This cortisol interferes with the uterine contractions pattern, and there will be delay in the progress of the labor, and if there is delay in the progress of labor, that will lead to operative interference definitely, and patient will land into the cesarean section. So to prevent that, we should give some distraction to the patient by following these techniques. And how this distraction technique works, It works on gate control theory. As per this theory, pain signal is interrupted in the substantia gelatinosa of the spinal cord, which acts as a gate, and it blocks the transmission of painful stimuli to the brain, and it sends other signals to the brain. That is the other techniques we are using for distraction, and this way the pain relief is felt to the patient. So we can use various distraction techniques, either visual distraction or auditory distraction, or tactile stimulants may also be given. This is a study which is published in the PubMed, and they have seen that the effect of distraction techniques on the pain and stress during labor, and they found that reduces the pain and that distraction techniques reduce the pain and stress of the labor. So that means provide a positive birthing experience. So we should follow these distraction techniques, and these are mentioned in our Ayurveda text, and that is very evidence based. Next thing they have mentioned is Abhyang Parshva Prisht Kati Sakti Koshna Tel Abhyang should be done. We know that massage is the systematic touch and manipulation of the soft tissues of the body. It promotes relaxation and gives stress relief, and it is also a non invasive form of analgesia during labor. We know it induces calmness and releases oxytocin, which further leads to contractions of the uterus, releases endorphins, which provide natural pain relief. That's why massage therapy is again a pain relief therapy or non pharmacological pain management intervention. It should be followed during the first days. It works by stimulating the pressure receptors, which ultimately project to the limbic system. And we know that limbic system is the emotional brain. So it provides pain relief, and it reduces the secretion of stress hormone, that is cortisol. So enhances the uterine contractions, enhances the progress of the labor, and ultimately a positive birthing experience is there. One study has been done in which massage was given to the pregnant patient, and they have seen that the group in which massage was given to the pregnant patient in the first stage of labor, there was less pain intensity during the phase 1 and phase 2 dilatation of the labor. This is the article which is also published in the PubMed. Next thing which Acharya has mentioned during the first stage is Ushnodak Parishechana should be given. That is showering or hot water shower should be given during the first stage. We know that warm showers relieve pain. They encourage mother to shift positions, thereby facilitate the rounded progression of the fetus, facilitate the fetal descent to the birth canal, and also relieve the labor pain. So this is also a non-pharmacological pain management intervention which should be practiced during the first stage. Next, they have focus on the nutrition. That nutrition should be given during the first stage. As the patient is contracting, her energy is being used. So, Balkarak Yavagu should be given. Yavagu, we know that in Ayurveda, Yavagu is Bahusikta. And pharmacological action are it is Balya, it is Tarpaniya, as well as Vatnashni. So that means it is a strength promoter. It provides strength to the mother to bear that pain, or to forcefully expel the fetus outside. And it is also nutritious, provides nutrients to the mother. So nutrition should be provided during the first stage. WHO also recommends that we should not interfere in women's eating and drinking during labor until and unless there are any risk factors. If risk factors are evident, then we can withhold, or we should not permit the food. But if no risk factor is present, then we can allow the patient to take food as per her preferences. Next is positional changes or ambulation, that is mentioned by the name of Chankraman. Acharya has indicated that Chankraman should be done in the first stage of the labor. Here, Chankraman means mobility or adopting different positions like walking, sitting, standing, or kneeling, whatever position she wants to she should be allowed, because it reduces the duration, aids in the fetal descent, and increases the likelihood of normal vaginal delivery. The studies also indicate that maternal position has a very good impact on reducing the length of the labor, and it seems to decrease the operative interference in labor. So positional changes should be allowed. Next, Acharya has mentioned Paricharika Aswasan, that is reassurance and emotional support should be given to the patient. And there, Shruta has mentioned that Parinat Vyaska, Prajanan Kushla, Kartinakha Striya should be present around the pregnant, this laboring female. That means reassurance, emotional support, and motivation is the key to the management of normal labor, and we should allow the companion of choice, or in, in today's era, we can say the companion of choice should be allowed during the first days of the labor, and we should provide emotional support to the patient. Next thing is augmentation of labor. That means if there is anagat avi. Acharya has mentioned that avi is prasav kalja shul vishesha. There are special pain which occurs during the labor. That is means that is the uterine contraction. And if there is anagata avi, if avi is not coming at the proper time, then what we should do? We should give the dhumpan of Koot, Ela, Langli, Vacha, Chavya, Chitrak, and Chirval. These ingredients has been mentioned that should be used for dhumpana. So it is a type of aromatherapy. Inhalation of these essential oils, because most of the ingredients contain essential oils. So when we inhale, patient inhales these essential oils, then it is just like an aromatherapy, and it works on the severity of labor pain, as well as it enhances the uterine contractility. Because kusta is having 39 volatiles, there's oils present, and it is a CNS stimulant. So when there's stimulation of the CNS, then it causes neuromuscular coordination of the uterus and causes uterine contractility increases. Similarly, ALA is also volatile oils are present, and one study has been done in which it was seen that when laboring patient were allowed to have the aroma of ella during the laboring stage, that improved their oxygen use during the labor, and they improved their breathing capacity. So that's why maybe that's why ella has been mentioned. Langli, we all know that colchicine is very potent ingredient present in the langli, and which is having a very potent uterine contractile property. So when it is inhaled, it acts on the uterus and enhances the uterine contractions. Similarly, vacha is also having uterine stimulant effect, and chabya is also a stimulant. Chitrak is also having uterine contractility property. So all the ingredients maximum are katu rasa and ushna virya. They have stimulant properties. They stimulate the uterine contractions. So when the avi is not proper, then we give the dhumpana of these ingredients to enhance the uterine contractions for effectiveness. Uh, this therapy works as when the odorant molecules trigger the electric signals within the olfactory bulb. The axons extend to the pyramidal cortex, then that goes to the limbic system, and we know that limbic system is our emotional brain that is responsible for the emotions, behaviors. So ultimately, that response goes to the cerebral cortex, and accordingly, with pain relief is also there for the patient. So along with pain relief, it also having uterine contractile property, so also enhances the uterine contractions. In this way, this dhumpana works. So all this management has been mentioned in the first day. So we see that acharya has mainly focused on the pain management interventions and various techniques to enhance the progress of the labor and to make this experience very fruitful or very positive for the patient. Now coming to the second stage, which has been named as upasthit prasva. Clinical signs has been mentioned as there is kati prisht prati samantat vedna bhakti. That means severe pain exists. Now there is excretion of the mutra and purish, that indicates that the second stage is now started, and discharge of the sleshma from the yoni mukha is there. By the name of Parivartit or Avak Prasvacharya, Charak and Kashipa has mentioned, and same features they have also mentioned. Along with that, Acharya Kashipa has mentioned that now the patient feels severe compression or tearing pain in the vagina. That means now perineal stretching is there. So this correlates with the second stage of the labor. Now, what management should we follow during the second stage? Here we see that Acharya has mainly focused on perineal care techniques, that how we have to prevent the perineal tear. For that purpose, they have mentioned that apatya margam talen sambhajya samantatah. Apatya marg should be oleated with the tala during this stage, and this yoni abhyanga should be done in the anuloman, should be done in anulom direction. That is, we can do the perineal massage like gently inserting our thumb and finger into the uh, vagina, and firmly we will sweep it downward and then towards the side to side. In this way, perineal massage should be done with the oil during the second stage of the labor. It will prevent perineal tears, including third and fourth degree lacerations. It will reduce the need for episiotomy. It will lubricate perineal muscles and will enhance the stretchability of the perineum. And it will also help the episiotomy if given to heal adequately in the postnatal period. And perineal massage during labor also shortens the duration of the second stage of the labor. So, during second stage, mainly Acharya has focused on the perineal care. So, studies has also been done on it, and it has been found that perineal massage has a significant effect in reducing the perineal trauma, and also helped in the decreasing the duration of the second stage of the labor. So, perineal massage should be given with the oil during second stage of the labor. Along with this management, Acharya has also recommended some instructions what we should follow during the labor. First thing, they have given Prabhahan Nirdesh, that is Avi ke saath hi Prabhahan kare. That means with contraction, bearing down should be done. Without contraction, bearing down should not be done. In modern sciences also says same, that with contraction only bearing down should be done. बिकॉज अकाल प्रवाहनात् श्वास का शोष प्लीहा प्रसक्ति और अकाल प्रवाहनात् बधिर मूक व्यस्त हनु मूर्धा विघाति का श्वास शोष जनयति. Because if the premature bear down will be there or akal pravahana will be there, then there may be a uterine dysfunction, and if uterine dysfunction is there, there may be fetal distress. Fetal distress will lead to meconium passage, and that will lead to oxygen deprivation in the fetus, that there may be death of the fetus, or there may be several abnormalities will be there. That's why premature bearing down efforts should not be done. Apart from that, Acharya has mentioned that Vimukt Garbhanadi Prabandh Shroni Vangshan Vasti Shirashul Shana Pravahit. When these symptoms appear, they are the symptoms of first stage or Asana Prasava. When these symptoms appear, then Shana Pravahit. That means initially small effort should be used. But when the Garbha Nirgam Smaya is there, that means when the fetus is ready to expel or second stage has started, then Pragad Pravahit. Then uh, this bearing down effort should be increased. And when garbha presents at the yoni mukha, that means garbha presents at the perineum, when perineal stretching is there, then gardtaram pravaha, that means at that time extensive bearing down effort should be done by the woman, and we should instruct the woman to follow this pravahana nirdesh as per acharyas. Now coming to the third stage of labor, which is known as aprapatan. All Acharya has mentioned this stage, and they have mentioned that only after the expulsion of the fetus, one of the attendants must inspect carefully that whether apra is expelled or not. And if apra is expelled, then only woman is termed as sutika. So this has been mentioned for the third stage. Acharya Bhaishajya Ratnavalikar has mentioned the apathyas, which should not be followed during the prasava. They have mentioned that Shram, Nasya, Raktmokshan, Maithun, Vishamashan, Viruddh Anprayog, Vega Varod, Asatmaya, Ati Bhojan, and Divanidra, Abhishandi Bhojan, Vishtambhu Guru Bhojan. These should be avoided by the laboring woman during the process of labor. So these are apathyas or contraindicated during the prasav kala. So coming to the conclusion, management of labor is a dynamic and critical process. To ensure the safety and well-being of both mother and baby, we should have a careful monitoring. We should follow timely interventions. Effective communication between the patient and healthcare provider should be there. We should adhere to the evidence-based guidelines as mentioned by WHO and as mentioned in our text. We should maintain a patient-centered holistic approach through Ayurveda interventions, which is mentioned in our text. A very holistic patient-centered approach is there. So we should follow all these interventions, and promptly we should address any complication, and we should emphasize on the emotional support. Then we can contribute to positive birthing experience and can lay the foundation for newborn and safe recovery of the mother. Thank you.
So thank you, Jasna. Very, very nicely you have presented your whole the topic, whole labor you have explained in one presentation. It's really excellent presentation.
Actually, topic was very vast, so I
Yeah,
tried to manage.
you have presented all the scientific evidence also of Ayurvedic Prasva Paricharya. So it was really excellent. Very nice presentation.
Thank you, ma'am. Thank you.
I'm proud of you. And now I would like to invite Dr. Tina. She will throw light upon the how we assess the status of the mother and fetus and how we take care of them during labor. Dr. Tina, over to you. Tina is there?
Mm. Yes, madam. Namaste to one and all.
Yeah.
Firstly, I would like to thank ma'am for giving me this opportunity. So, as ma'am has already described that I am basically focusing on the monitoring part. So, ma'am, I'm audible now.
Yeah, you're audible.
Uh, So basically, ma'am has already covered all the events, assessment, and as she has already mentioned, monitoring is very important part. So we will basically focusing on the fetal and maternal monitoring. Firstly, we'll go through fetal monitoring. So fetal surveillance is important because labor is very stressful procedure for a baby as the baby descend through the and follow the passage through pelvis, then cervix and vagina. It has to descend and face all the contractions. So when the contractions arises, so fetus feel the pressure or a stress. So it might go in hypoxia, but this question might be arise in our mind why every fetus is not going in hypoxia. So God has already designed the placenta in such a way, as you can see in this picture, the chorionic villi with the intervillar space, there is always exchange happening between them. In intervillar space, there is spiral arteries which are in perpendicular form and veins are in parallel form. So when the contraction arises, artery do their work in the same manner, but vein are obstructed due to the contraction. So when the pressure come or when the contraction arises, so fetus is getting the oxygen. So if there is no risk factor or any sort of abnormality is not there, so fetus can cope up that condition or cope up all those contractions. So why we require monitoring? So one thing is that we have to know fetal is compromised for oxygenation. Fetus is getting oxygenation properly, or there might be a condition of hypoxia. Secondly, if there is a hypoxia, if we are monitoring properly, so we can timely take the decision what we have to do next, where we have to be suspicious conditions or where we have to intervene. So that decision making is dependent only on the monitoring. Other thing, we can prevent the brain injury by taking the step immediately as per the condition required. So there are various methods as the technology is developing. So many tools are developing. So there is intermittent auscultation, which are commonly used, in which a handheld Doppler is used. Then there is cardiotocography, which can be done externally as well as internally. Then fetal scar blood for pH or for lactate, fetal ECG, fetal pulse oximetry. So we'll see one by one. So first is intermittent auscultation. So first question is when we have to choose or in which cases we can choose intermittent auscultation. So when there are low risk cases like female is primary or she is having previous normal delivery and no any sort of maternal medical condition is there, so we can go for intermittent auscultation. This can be done by a Pinard stethoscope or a Doppler ultrasound. So we can use handheld Doppler, and by placing the handheld Doppler on the site where we find the sound very clearly for a 1 minute, we can count the fetal heart sound. So this can be done after the contraction. Why it is done after the contraction? Because after the contraction there might be fall in the heart rate. So to notice any sort of deceleration, we have to auscultate just after the contraction. So how often we have to auscultate? In the first stage, we have to auscultate 15 to 30 minutes, or in second stage, in every 5 minutes, we have to auscultate. So we have to record a rate. We can't record a range. Like there will be like 144 beats per minute, 148 beats per minute. It is not like 140 to 148 beats per minute. Will be a accurate number. Then acceleration and deceleration, if any, we have to note it. And after every contraction, we can auscultate and note the fetal heart rate. So where we can auscultate, so there are different position of the baby, or we can say the alignment. So in this picture, the dot is localizing the best point to auscultate the fetal heart rate. So in the first picture, we can see the commonly presentation, longitudinal presentation and vertex presentation. So we have to auscultate between anterior superior iliac spine and umbilicus. Between that, we can auscultate. And where is the back of the baby, the clear sound will be there. In above two pictures, we can auscultate either on the left side or right side in between the umbilicus and the anterior superior iliac spine. In the middle two pictures, where the baby faces towards the mother abdomen and back is towards the mother spine. So in such cases, the fetal heart sound more towards the flank side. And in breech presentation, fetal heart sound will be more close to the umbilicus or around umbilicus. It will be heard clearly. So these are the locations where we have to auscultate fetal heart sound. So fetal heart sound, as ma'am already mentioned, the normal range is 110 to 160 beats per minute. So where there is a tachycardia, where there is a bradycardia, such common conditions are like in tachy seen mainly in fetal distress, maternal tachycardia, which might be in fever, sepsis, chorioamnitis, arrhythmia. Bradycardia, if fetal heart rate is less than 110 beats per minute, so it might be seen in fetal distress, cord compression, maternal hypertension, abruptio placenta, arrhythmia. So, if there might be chances we are not able to get any sort of fetal heart rate, so in such cases we can ask some other person, our senior, to auscultate. If that is not possible, we can immediately advise the patient for an ultrasound or a bed scan is advised. If we are not able to differentiate, we can change the, if there are two positions where we feel that this is the site of heart rate, then we can switch for the monitoring method. And if there is a rise in 20 beats per minute from the start of labor, it might be fall or increase. That is the acceleration or deceleration. It is not important in the beginning. If the heart rate is 130 and now it is raised to 150, then it is also a deceleration. It is not important that heart rate will go above 160, then it will be a deceleration. From the beginning, we have to calculate the change in the heart rate. So if any sort of deceleration is noted, we have to auscultate for 3 consecutive contractions. This is called intelligent auscultation. When we find such a condition where there is a fall of 20 beats per minute, then we have to auscultate consequently. Then we can take a time for 15 to 30 minutes for next auscultation. As 3 contractions are normally seen in 10 minutes, that was a good condition. So we are auscultating after every 3 consecutive contractions, so we can observe any deceleration if there. Then which are the conditions where there is a heart rate concern is there? Then what we can do, we can take help of other person or we can advise for continuous CTG monitoring. So this is advise, if there is no availability of CTG monitoring, we can refer the females for higher center and explain the need of the CTG monitoring. If the 20-minute trace of the CTG monitoring is normal, we can again return to intermittent auscultation. And if a female want to continue with the CTG monitoring, so she can continue with the CTG monitoring. So where we can advise continuous CTG monitoring, this is also important. If there are concern in intermittent auscultation, we can go through the continuous CTG monitoring. If female want to continue, then we can continue with the CTG monitoring, or there is any intrapartum maternal or fetal risk is there, so we can continue with the CTG monitoring. So what is the CTG monitoring or cardiotocography monitoring? As the name already said, cardio and toco. There are two probes. This is the machine which has two probes, for one for cardio, that is for the FHR, and then other is for toco, which measure the pressure of a contraction. And there is a handheld pen also there, which will mother will press when she perceives the fetal movement. And on the screen, we see a graph of fetal heart rate as well as uterine contraction. So these two graphs will be visualized on the screen, and we can also get the print of these trays and compare the fetal heart rate as per the contraction. So where we can do continuous CTG monitoring, where it is advised. So indication are like that if in antenatal period mother is having a history of previous cesarean section, any hypertensive disorder, prolonged rupture of membrane, or any blood loss other than show, suspected chorioamnitis, pre-existing diabetes and gestational diabetes that require medication. So all such conditions are sort of condition which are giving a risk factor so that we have to monitor more frequently or for a longer duration. That is why CTG is advised. In antenatal period, other factors are like non-cephalic presentation, because in non-cephalic presentation there is chances of cord compression or mood, fetal growth restrictions, small for gestational age. Then there is advanced gestational age. In advanced gestational age, there is a chances of oligohydramnios, anhydramnios, or polyhydramnios, as there will be frequent fluid loss or frequent rupture of the bag, which will also increase the chances of cord compression. There is reduced fetal movement for more than 24 hours before the contraction arises. In intrapartum period, if the contraction is for more than 2 minutes or 5 or more contraction in 10 minutes, that is defining a tachycystal. So, if there is such condition, we have to be more vigilant, and CTG monitoring can be a better media for monitoring. Presence of meconium, maternal pyrexia, chorioamnitis, sepsis, or any sort of pain female is defining which is different than the contraction pain, or there is some fresh bleeding, blood stain liquor. All such conditions are required more vigilant observation. So CTG monitoring can be used in such condition. Also, maternal pulse is over than 120 beats per minute, or on a two occasion between 30 minutes. Or there is severe hypertension, like 160 to 160 oblique 110 is her BP, or in two consecutive reading, we find 140 by 90 mm of Hg between 30 minutes. Or there is a, when we do urine examination, there are 2 plus uh, urine on the reading, or there is systolic pressure greater than 140 or diastolic pressure more than 90, or there is confirmed delay in first or second stage of labor. As we already know, there is a prescribed time like 12 hours for first stage for primary gravida and 8 hours for the multigravida. So if the labor stages are going for a longer period, then this confirm a delay. So we we need to be more vigilant in such condition. Or insertion of regional analgesia, use of oxytocin. In such condition, we require more frequent monitoring. Or there is presence of meconium. So meconium is a sign of fetal being compromised. Or there is chances of complication like meconium aspiration syndrome. So in such condition, we need to be more vigilant. And mostly post-term baby, there are chances of meconium stain liquor. So when we do a CTG trace, there are some factors we have to assess. First is contraction, then baseline fetal heart rate, beat-to-beat variability, presence or absence of deceleration, and then presence of acceleration. One by one, we will see how we have to monitor all these factors on a CTG trace. So contraction, as as manually we can place our ulnar side of hand on the maternal abdomen on the fundus of the uterus and palpate the contraction. So if the color coding is used for all these factors, so if there are contraction less than 5 in 10 minutes, then it is coded as white. Amber is coded for 5 or more contraction in 10 minutes, or this indicates hypertonus. There will be decreased time between the two contractions. If 5 or more contraction are present in 10 minutes, then we need to be assess all the risk factors and take action to reduce such contraction. Then next factor is baseline fetal heart rate. So for calculating the baseline fetal heart rate in a CTG trace, we need to observe a 2-minute period where there is no acceleration and deceleration. In this picture, we can see the red zone is the red line is indicating a period of 2 minutes. where there is no acceleration, and we can see it is lies close to 150. So the baseline heart rate for this CTG trace is around 148. So if the baseline fetal heart rate is in between 110 to 160, then it is white. If it is if baseline heart rate of there will be increase of 20 beats from the start of the labor, like in initially we have seen 140 and now it is 160, then it is a amber, or it is between 100 to 109 beats per minute, or we are unable to determine the baseline. There are so many changes, so it is also come in amber. And in red, if it is less than 100 beats per minute or above than 160 beats per minute, so accordingly we can code the baseline fetal heart. This is the second feature. Then, if there is a lower baseline heart rate is seen in postterm pregnancy and higher baseline in preterm pregnancy, and rise in baseline indicates infection or hypoxia. And if the baseline heart rate between 100 and 109 beats per minute is the amber feature, we can continue the procedure and be more vigilant, and see there is if there is normal variability, so no other intervention will be required. We have to just wait and watch. Then next is variability. In a CTG trace, uh, we can see this CTG trace. There will be a ziggliness or there will be a babiness in the graph. The fetal heart rate is changing every beat. So this beat to beat variability is a sign of proper working of an autonomous nervous system of a fetus. So this beat to beat variability or this oscillation is required 5 to 25 beats per minute. In this, we also take a small portion of the graph where there is no acceleration or deceleration is there. In such case, we can see like the arrow are symbolizing a short span of period. We can see there is a variability from 120 to 130. So almost 10 beats per minute there is a variability. So if there is 5 to 25 beats per minute variability is there, or fetal heart rate change is there, so it will be coded as white. If it is less than 5 for a period of 30 to 50 minutes, then it is amber, or more than 25 up to 10 minutes, it is also a amber feature, and coded as red if less than 5 beats per minute for more than 50 minutes, and more than 25 beats for more than 10 minutes, or a sinusoidal pattern. Later, I'll describe the sinusoidal pattern. This is also a different type of variability described on this. The first one is where there is no variability. Variability is completely absent. This is a poor CTG graph. Then there is a minimal where variability is less than 5. 6 to 25 is a moderate variability, and more than 5 there is marked variability. 6 to 25, all these are different type of variability on a CTG graph. The 6 to 25 one is a normal one, rest are abnormal. Then why there is a decreased variability? In this graph, you can see there is a variability, but very less. So there are some condition where there is decreased variability. If fetus goes in a sleep, so fetal not sleep like normal individual. They sleep for 75 minutes, then wake up, then do some movement. So when we monitor for 90 minutes, so variability changes. If there is prematurity means less than 30 minutes, 30 weeks. So if a fetus is less than 30 weeks, their autonomous nervous system is not properly developed. So in such cases, there is decreased variability, or we have used any analgesic drugs. Mother has taken some analgesic drug, or fetal hypoxia, fetal brain hemorrhage, fetal infection. All these conditions reduce variability. The integrity of the autonomous nervous system is defined by variability. So good variability, beat to beat variability shows that fetal is going well. So intermittent period of quiescence is present in when baby sleep. So for that we have to monitor for 90 minutes and then see there is any change in beat to beat variability. If it is going towards worsening condition, then we have to take immediate step. Why when we have to urgent review or consider expediting of a birth if beat to beat variability is less than 5 beats per minute for 30 minutes, or there is some risk factor and antenatal or intrapartum. So there is an increased risk of adverse neonatal outcome. So we have to immediately do the delivery of the baby. If there is reduction in the variability to less than 5 beats per minute, and there is combined other CTG changes like there is a decelerations or fall in fetal heart rate, then it is a strong indicator of a fetal is compromised. Now the next thing is deceleration. Deceleration is a fall of fetal heart rate from the baseline. So it is about 15 beats per minute fall from the baseline fetal heart rate, and it is for a period of 15 seconds or more. There are different type of deceleration depending upon the timing in relation to the contraction. There is early deceleration, variable deceleration, or late deceleration. After a deceleration, fetal heart rate goes back to the normal baseline. Or if the deceleration occurs more than 50% with more than 50% of contraction, then it is defined as repetitive. In deceleration, there is also seen presence or absence of shouldering. So first one is early deceleration. Early deceleration are the deceleration which comes with the contraction. The trace of the fetal heart rate is just a mirror image of the contraction. When the contraction and the early deceleration also. Late deceleration are start in between the contraction or after the contraction goes, then ends later than the contraction goes. So this is started late than the contraction, as the name suggests, and it is mostly seen in fetal distress and fetal hypoxia. Variable deceleration, there is no relation to the contraction. They comes anytime. So firstly, early deceleration. Early deceleration are the good deceleration. They are basically due to head compression. When the fetal head descends, so it will feel the pelvic floor pressure, perineum pressure, contraction. So all those pressure, due to all such pressure, the fetal head compresses and vagal stimulation will occur, which followed by drop in the fetal heart rate and shown as early deceleration. When the contraction goes away, fetal heart rate come back to normal. This is a trace showing early deceleration. The deceleration is in the above picture. Above graph you can see the fetal heart rate. There is a drop, and which is similar to the mirror image. The contraction shows in a lower graph. Then next is the late deceleration. Late deceleration basically seen mid of the contraction or just after the contraction and ends later than the contraction ended. This is a delayed onset of the deceleration, then the contraction, and ends later even when the contraction ended. This is a late deceleration. So where we see the late deceleration, if there is a uteroplacental insufficiency, fetal hypoxia, fetal distress, maternal hypertension, epidural analgesia, placenta abruptio, excessive contraction. So in such condition, what happens as there is a uteroplacental insufficiency, so there is a decreased oxygen. The chemoreceptor of the artery activates and fetal heart rate falls. So in this condition, fetal goes in a distress. Then there is a variable deceleration, which is mainly seen in cord compression. And cord compression is most commonly seen in oligohydramnios or decreased FI, postpartum pregnancy, malpresentation. Malpresentation, there will be cord compression. So basically, cord compression is the main cause for variable deceleration. When the cord compresses, umbilical artery compresses, and there is a rise in systolic blood pressure and drop in fetal heart. So this is the reason of fetal distress. So variable deceleration is not in a relation with the contraction. It occurs anytime. You can see in this graph, the variable deceleration are not in a relation with the contraction. They are coming in between the contractions. So there is no fixed time. As well as there is an important feature of these variable deceleration. You can see there is a shouldering in the beginning and in the end of the deceleration. And in a variable deceleration, there is a sudden fall. It is not slowly. Earlier we have seen early deceleration, late deceleration. In this, we can see there is a slow fall in the heart rate. But in a variable deceleration, we can see there is a immediate fall of the heart rate. So when these variable deceleration are concerning, so if they are lasting for more than 60 seconds and there is a reduced variability between the deceleration, or if the heart rate is not returning to the baseline, or the shouldering is absent, so all such variable decelerations are concerning. Then there is other term which is prolonged deceleration. Prolonged deceleration which is occurring for more than 2 minutes but less than 10 minutes. If it is more than 10 minutes, then it is known as fetal bradycardia. It is commonly seen in cord prolapse. This basically lead to hypoxia and immediate delivery is advised. Then there is a sinusoidal pattern. This is a sine wave-like pattern. There is no variability in the graph. This is a sign of fetal distress and mainly seen in fetal anemia. Fetal anemia can be happen in fetal intracranial hemorrhage, severe fetal asphyxia, twin-to-twin transfusion syndrome, vasa previa. Vasa previa is bleeding from the baby, or RH isoimmunization. In such condition, we will see sinusoidal pattern. This is a sinusoidal pattern. There is no variability. Just sign-like graph is seen. So we have seen coding earlierly. In deceleration, white code will be given to if there is no deceleration, early deceleration, variable deceleration, but there is no concerning characteristic in the variable deceleration. In amber, there is repetitive variable deceleration, but there is no concerning character and therefore less than 30 minutes. Variable deceleration with concerning feature for more than 30 minutes, repetitive late deceleration. In red code, there is repetitive variable deceleration with concerning character for more than 30 minutes, repetitive late deceleration for more than 30 minutes, acute bradycardia. All such conditions are denoted as red code. Now, the important point is acceleration. Acceleration are always a sign of good. But if they are not present, that it doesn't mean there is some risk. So acceleration is always shown by a rise in a fetal heart rate from the baseline heart rate. So if there is rise of 15 beats per minute from the baseline for more than 15 seconds, this is a sign of a acceleration. Acceleration can happen with the fetal movement. So if there is acceleration and reduced variability, then it is also a sign if baby is healthy. And if it is not present, then it is also not a point to worry. So we have covered all the point: contraction, baseline fetal heart rate, acceleration, deceleration. All these things will be monitored on a CTG graph. So accordingly, categorization will be given to normal, suspicious, and pathological. Normal condition, when there is no amber or red feature, all are white. So we can continue the CTG monitoring and continue to perform risk assessment and monitoring early. If there is one feature of amber, then it is suspicious. Then we have to do risk assessment. We have to see there is any acceleration is present, or if CTG trace was previously normal, now why abnormality has arisen. We have to assess the cause. Is there is any meconium, sepsis, slow progress, that we have to suspect. If it is there are one feature of red and two or more of amber, then it is a pathological CTG trace. So then we have to take an urgent review, exclude any acute event like cord prolapse, placenta abruption, uterine rupture, and take immediate intervention. Full risk assessment is required, and we have to do conservative measures. So what conservative measure we can take and for what causes, we'll see now. So if maternal position is also a reason, if a mother is lying in a supine position, then there might be a chances of hypertension. So if there is a chances of hypertension, we can advise mother to change the position to left lateral or sitting position, or we can give IV fluids. If there is sign of hypertension or sepsis, then only IV fluids are advised. Other than that, if we see a fetal heart rate abnormality, then no need of IV fluid transfusion. If there is excessive contraction, then we can stop the oxytocin. As oxytocin is having half-life of 3 minutes, immediately we can see the change in the fetal heart rate. Or if it doesn't happen, then we can give tocolytic drug. Among that, subcutaneous terbutaline 0.25 mg is most commonly used. So we can take all these steps. So earlier it is mentioned as reassuring, non-reassuring, and abnormal CTG traits. So if the baseline is 110 to 160 beats per minute and beat-to-beat variability is 5 to 25 beats per minute and there is no deceleration and acceleration are present, then it is a reassuring. Then we have to just monitor and we have to continue the CTG trace. When baseline is between 100 to 109 or 161 to 180, then it is a non-reassuring and beat-to-beat variability is less than 5 or greater than 40. Less than 5 for more than for 40 to 90 minutes, then it is non-reassuring. Or early acceleration, variable deceleration, or single prolonged deceleration up to 3 minutes is present, or there is absence of acceleration, then it is non-reassuring. That is a suspicious condition. We have to find out why these changes are happening. And then there is a abnormal CTG graph when the fetal heart rate is less than 100 or there is a sinusoidal pattern. Uh, Earlier it is said that if the heart rate is more than 180, then it is abnormal. From current guideline, it is 160. As nobody will wait for the time to for fetal heart rate to reach 180. If the variability is less than 5 for more than 30 minutes, more than 90 minutes, or no variability is there, then it is a abnormal trace. Or a atypical variable deceleration for more than 30 minutes, 3 minutes, there is a prolonged deceleration. Recurrent late or variable deceleration, then it is a abnormal trace. This is a normal trace. In this, we can see there is a early deceleration which coincides with the contraction. So this shows a normal trace. As there is a variability there, everything is indicating the positive sign. In this, these trace, we can see in the first trace, there is variability is very less. And in the second trace, we can see there are repeated variable deceleration. So all these indicates the abnormal trace. So if there is an abnormal trace, we need to deliver a baby immediately. If it is non-assuring, we need to be more vigilant. We can hydrate patient, change its position, and according to the condition, we have to take the step. If it is assuring, we have to wait and watch and continue the same. The most important thing is that the CTG tracing is basically advised where there is a risk factor. It is not a indicative or decision making. As it is a tool, we have to make the clinical assessment also along with that. Then we can also predict the needed step. Then there is also internal fetal monitoring, as we have seen CTG monitoring externally. This is the internal method. This is not commonly used. It is also can be done when the 3 centimeter of dilatation of the cervix is already happened and membrane are absent. In such cases, we can do the internal fetal monitoring. In this, intrauterine catheter is passed to measure the contraction, and a probe is placed on the fetal scalp to measure the fetal heart rate, and a graph is obtained like a CTG trace we have seen earlier, and monitoring of the fetus is done in such a way. There is also another method which is telemetry. Advantage of this method is that there are charge electrodes which can be placed on the maternal abdomen, and she can walk up to a area where there is a range of the signal is there. So it is not required to lie down in a supine position, which is required in the CTG tracing. So this is the advantage, but this is also not used in India. There is also another method, fetal scalp stimulation. This is helpful when there is a sign of fetal sleep, or we can if there is no acceleration, we can manually or pervaginally just irritate the fetal scalp and or give a stimulus, and then we can see the acceleration in fetal heart rate. If there is no acceleration, then it is a sign of worry. Then we have to take immediate step for delivery, or suspect the cause if there any, or if we can evaluate if fetal is compromised. Other method which is used, fetal scalp blood pH and lactate levels. This is also possible if the cervix is dilated 3 centimeter, membranes are absent. In this, a probe is passed intercervically, and on a scalp, a small incision is taken, and then blood is taken out with help of this instrument, and then it is assessed for pH and lactate level. If it is pH is more than 7.25, then it is normal. If it is between 7.21 to 7.24, then it is borderline. If it is less than 7.20, then it is abnormal and acidotic fetus or fetal hypoxia. Same for the lactate level. If we see if it is normal, then we can continue. If it is a borderline, we have to repeat it after 30 minutes. If it is abnormal, then we have to take immediate step for expedite delivery. So this is all the fetal monitoring part. Now we will move towards maternal monitoring. So for maternal monitoring, we require detailed history. Any sort of maternal complication is there, we have to evaluate in the detailed history. Then physical examination is done. Per abdominal examination is done by Leopold maneuver and fetal heart rate auscultation. Leopold maneuvers are done. There are 4 grips: fundal grip, lateral grip, polygrip, grip, and pelvic grip. With the help of fundal grip, we'll just assess the level of the fundus and assess the gestational age accordingly. If it is the level of pelvis, then it is 12 weeks. If it is the level of umbilicus, it is 24 weeks. Accordingly, with the help of fundal grip, we'll assess the gestational age. Then second is the lateral grip, which all these grips are performed by facing towards the patient and standing on the right side of the patient. So we'll palpate the lateral sides of the abdomen and accordingly find where is spine is present and where is the knobs of the limbs, and accordingly we can assess the position of the baby in the abdomen. Then there is polygrip. This is done with the right hand. In between the thumb and index finger, we'll palpate the presenting part, whether it is head or it is buttock, or it is, if it is transverse, then we'll feel a broad part or not a bony part. So with the help of polygrip, we can identify the presenting part. In pelvic grip, we can analyze the descent. This is the only grip which is done by facing towards the feet of the patient. If the hands converge, then it is fetal head is still floating. It is not engaged. If the hands diverge, then fetal head is already descended and engagement is happened. So all these Leopold maneuvers are done to identify the position of the baby in the abdomen. Then presenting part is present at the lower uterine segment. Presentation, sorry, we can analyze at the lower uterine segment, and presenting part which is present at the internal nose, and accordingly position in the maternal pelvis will be assessed with the pervaginal examination. So this is already covered in previous presentation. We can assess the position of the head in the by the pervaginal examination. So PV examination basically done to assess the dilatation and effacement, status of the membrane, whether membrane are present, flat, rupture, or color of the liquor, whether clear, meconium stained, or blood stained, position of the fetus, or station. Station is assessed by palpating the ischial spine. If the biparietal diameter has crossed the pelvic brim and head is at 0 station, then it is known as engaged. This is also helping in the judging the progress of labor. So important all these things we have mentioned earlier, PA examination, PV examination, all these help us in plotting partogram. Partogram is basically a graphical record, and on this, each and everything is mentioned. Dilatation, all the 11 things which ma'am has already mentioned are placed on the partogram. So this is the partogram which was earlier used. In this, there is a latent phase, active phase, but now it is modified. There is no latent phase, only active phase is there, and alert line and action line. So the new partograph has modified WHO partogram is having all these features. There is no latent phase. General details of patient is on the partogram. Time on the x-axis. FHR is recorded every 30 minutes. Color of the liquor is noted, whether it is clear, blood stain, meconium stain. Cervical dilatation on the y-axis. There is alert line which is starting at 4, and 4 hours later there is a parallel action line. When the action line, when we have plot and it cross the action line, then we have to take immediate step. And alert line, if alert line shows a dilatation of 1 centimeter per hour, uterine contraction for 10 minutes is plotted every half hourly on it. Drug medication, IV fluids, women pulse, and BP is also plotted on partogram. This is a partogram which ended up in a cesarean section. You can see on the top, fetal heart rate is monitored or plotted every half hourly. It is started from when the cervical dilatation is 4 centimeter, and then plotted at 1 p.m. it is 6 centimeter, and till 4 p.m. it goes to 6. It remains on 6 centimeter, and when we see the descent, we can see it is also it is on a -3 station and remains on that. So it indicates, and below that there is a contraction is plotted on the small cubes, and it is plotted every half hourly. The slant line indicates moderate contraction. So there are and darker zone indicates strong contraction. So there are strong contractions. Still, the fetal descent is not there. So fetal arrest is happened. So it finally ended up in cesarean section. Below that, you can see there is a graph indicating BP, pulse, urine protein status. All this is plotted on a partogram. So this will help to assess what step we need. If someone else has to observe the patient, he or she can analyze it by just observing just a piece of paper, the whole event which has happened throughout from the admission till now. So this in this way, partogram helps. This is also a partogram of a normal vaginal delivery. So we can see the as the in the starting, it started with 4 centimeter dilatation. It goes just parallel to the alert line and doesn't crosses the action line. At 5 o'clock, the patient was in 10 centimeter and descended till 0 station. And contraction are good, and finally it will ended up in normal vaginal delivery. So by plotting the partogram, we can analyze when we have to act, and all the things are mentioned which are happened in the period of observation or in a what we have done till the admission till now. So in this way, partogram help in maternal monitoring. So this is all fetal monitoring and maternal monitoring, uh, how we can assess. Thank you.
Thank you, Tina. Very nicely presented your portion. How we can assess fetal state and maternal state, and how we do fetal monitoring and maternal monitoring during labor. Nice presentation, Tina. So I think
एक्सीलेंट,
we,
रियली एक्सीलेंट मैडम. दोनों
yeah,
के प्रेजेंटेशन बहुत शानदार थे. दो इट इज नॉट अवर सब्जेक्ट, लेकिन फिर भी जो समझे वो अब इस एज में बहुत अच्छा समझे. ग्रेट. आपके सिलेक्शंस और इन लोगों की कैपेबिलिटी और कैलिबर रियली ग्रेट.
जी, थैंक यू वेरी मच. सो अभी क्वेश्चन लेने का तो अब मुझे लगता है टाइम नहीं रहेगा. सो नाउ वी विल एंड अप दी सेशन विद द कमेंट्स ऑफ अग्निहोत्री सर.
अभी हमारी दो वेबिनार हैं, बता दूं आप लोगों के इंटरेस्ट की हैं. पहली वेबिनार हमारी है लाल बहादुर शास्त्री जी की पुण्यतिथि के उपलक्ष्य में सिंप्लिसिटी वाज हिज एम, तो हम सिंप्लिसिटी इसेंशियल फॉर फिजिशियन, तो ये भी बहुत अच्छा टॉपिक है। और उसके बाद जनरली महिलाएं जो हैं वो हर घर में गार्डन लगाती हैं, तो आज हाउस प्लांट डे है, तो उसकी टिप्स एंड ट्रिक्स की बात करेंगे कि हाउस प्लांट्स आप घर में जो लगाए हुए हैं उनकी रक्षा कैसे करें, कैसे बढ़ाएं, किसको कैसे पालें। तो दोनों ही इंटरेस्ट की चीजें हैं। आप लोग ऑडियो वीडियो अपना वीडियो बंद करके जुड़े भी रहेंगे तो कोई हानि नहीं है उसमें। आदरणीय अग्निहोत्री सर।
धन्यवाद प्रोफेसर पवन शर्मा जी, प्रोफेसर कामनी जी। एक्चुअली मुझे दोनों ही आज के अतिथि वक्ताओं को बहुत बहुत बधाई देनी है। बहुत ही अच्छे से प्रेजेंटेशन दिया, बहुत डिटेल्ड किया, जिसमें कि मेरी अगली वेबिनार का भी करीब 30-32 मिनट 25 मिनट खर्च हो गए। इसलिए